Oh,
All right, everybody ready? Before we start, does anyone have any questions, cases, anything you want to go over?
I don't want to look at myself. I want to look at them.
Is there a way, Dr. Gibson?
Huh?
Do they change it?
Okay, so Krista had wanted us to do a knee exam, so Krista.
Switch the themes or one.
Yeah, they switch it.
Yeah.
Is everybody muted? Okay, there's Krista. So we're going to go over and I'm going to do kind of a primary care knee exam. I want to make it simple and clear, and you can get a good idea of what's going on with your patient. We won't do a lot of complicated tests that you may or may not do, or that are a little bit harder. Ask questions along the way. I have a little PowerPoint that one of our fellows made for us a few years ago, just so you could use that later for reference. I think that'll be posted, right? So we'll put that up. I guess we'll put it up. Anyway, when a patient first comes in, before you ever get to the knee exam, of course you want to get the history. And there are a few things that are really important in the history. You know, A is when did it happen? And then I like to know the mechanism, exactly what happened, if the patient knows. Sometimes it's, I was going down the ski hill and I tumbled in a big ball and I don't know what happened, and when I got up, my knee hurt, or my knee hurt later. It's really important to me to know, could you get up and finish your activity and your knee hurt later, or no way. I was taken off the mountain by the ski patrol, I couldn't walk on my knee. And then the next thing that is really important to me to know is, did it swell or not? And if so, when? The things that will cause the knee to swell right away, you know, that are common injuries, are basically a patellar dislocation, and typically the patella goes laterally, and they will tear that medial retinaculum and get a lot of bleeding, and then, of course, an ACL tear. So things like isolated lateral collateral and medial collateral tears don't tend to swell a lot, and the meniscus tears may swell a little bit later or swell off and on, but they're not usually a big, acute, fat, swollen knee. So I'll say, you know, when did it happen? Gee, it was 4 months ago and it's bothered me off and on is a lot different than it was yesterday and I haven't been able to walk on it since. What was the mechanism? Did it swell? How long? And then how's it affecting your activities now? Gee, it happened 4 months ago, and only when I do a 9-mile hike, gee, it swells up a little bit versus I can't even get in and out of my car. And then I like to know, did you ever have any prior problems with your knee? And you can ask a whole bunch more questions, but that's really what I like to get before I start my knee exam. Does anyone have any questions about that? Okay, so walk into the room. Hopefully, it depends on your medical assistant, nursing staff, etc. But for mine, I really like to have my patient short so I can actually look at them. So if I walk in the room and my patient's in a pair of jeans, the first thing I do is hand them a pair of shorts and walk back out and say, get these on so I can come in and look at your knee. So typically, unless the patient has a big fat swollen knee and they can't bend it, my leg out there. This is my little knee exam roll that the nurses always know to put in. It's just a towel rolled up with some Coban, but I'll show you how I use it, especially for the people who have bigger legs. Sometimes I can't grab all the way around and I really want to relax. So if you want to make one of these, that's my knee roll. Anyway, the first thing I do is walk in. My patient's sitting here. We've gone through our history. She gives me whatever the history is, and I have the opportunity to just look at her knee. Well, the good news is I have a second knee to look at. So what I'm looking at initially is there any swelling? I'm looking at both of her knees. Of course, if you think you have any type of an infection, gee, if there's a big abrasion and her knee is swollen and red, you know, up to here, I have a little bit different idea. But the first thing you just want to do is inspect and look and say, hey, this looks okay. She has a big scar right down here, and may say, oh, what kind of a surgery did you have before? That's typically an ACL surgery. Maybe she has some scars from a scope. So you can just look at the knee and see, is there anything different versus the other knee? Big bruise, deformity. It would be really rare to see somebody with their patella off to the side. They would probably be in acute pain, but you just look at them. And then the next thing I like to do is I'll ask the patient, where does it hurt? Just put a finger on the place that it hurts. And she may say something point tender, but a lot of times the patient will do this. It kind of hurts in here. Like, okay. And even with an ACL, they'll still say, it kind of hurts in here. That intra-articular pain is sometimes hard to figure out. The patient gives me a really specific spot, you know, I may be thinking of some other things. But a lot of times it's kind of right in here, they'll say. So when I go to palpate the knee at first, and I have them bent already, this is a really nice time to be able to check the joint line. And so everyone's like, well, where is the joint line? How do I even feel it? Well, what I like to do is put my thumbs on either side of the patellar tendon, just below the patella. So I'm on either side of the patellar tendon, and I call them the divots. I don't know if you can feel your own knee, but there's a divot on each side. And I like to just, and typically I'll feel just one side and not both, because if I'm poking on both and the patient says, ow, I'm not really sure which side hurts. But if you want to just, you know, orient yourself, you can usually just find those divots. And then I'll take my finger and I'll just palpate along the joint line. And you can actually feel an opening there where the bones, you know, are separated by that meniscus, by that cartilage. And I just go all the way out. I get to her lateral collateral ligament here. And again, it's practice, but as I'm feeling along, I feel the joint line. I can definitely feel, you know, here's her fibula, here's her femur, and then all of a sudden there's something over the top of it. And that's her lateral collateral. So I feel that structure. Great. And then I get behind the lateral collateral and I feel all the way back in here. Back in the back, they'll have popliteal cysts, they'll have swelling. Sometimes a real posterior meniscus tear will present with just point tender pain back there in the back. So I'll go out along the joint line on one side, and then I'll come to the other side, and I'm always ask the patient, you know, let me know if any of that's tender or that hurts. And I'll palpate right along her joint line. I feel where I don't feel her separation anymore. There's her medial collateral, and I'll go around the back. And that's pretty easy. That's what I do when I have them sitting there. I also at the same time will then come palpate the patella, and I like to get just around the edges of the patella, because with patellofemoral syndrome, a lot of times they're tender up around that area. And that gives me a clue. If I have someone who's come in and says, gee, my knee only hurts when I do a lot of running, and when I go downstairs, and after I've been sitting for a long time, it hurts, and you know, I work out a lot, I'm particularly a runner, and I really don't see a lot of effusion, and I've done my exam, it's not really significant. I want to make sure that I've palpated right around the patella, because with patellofemoral pain, they will have some pain sometimes peripatellar. Then I like to feel the distal pole of the patella and palpate down the patellar tendon, and then to where it attaches there on the anterior tibia. A lot of adults that come in for me don't have problems there, but the kids can have problems either in either area. The distal pole of the patella is the Syndig-Larsen-Johansson syndrome. Again, it's kind of an overuse injury, and then you'll have the Auschwitz-Schlatter down here. Some of the jumpers, people who do a lot of jumping activities, may have patellar tendonitis. They'll be tender in that area. So that's what I do when I have the patient sitting there, assuming that my patient was able to sit there in bed. So does anyone have any questions about that part? Does that kind of make sense? Think you can feel that joint line? Someone? Can you push it down a little?
Yeah.
Yay. Okay. Now we're going to have to be tricky to, so then the next thing I like to do is and I typically have my patients lie down to do my exam, but we'll just let her sit because it's going to be uncomfortable to lie on here. So we'll flip you this way. So I get, okay, let me get you to lay down. And so I think we'll put this knee towards the camera. So switch this way, yeah. And you guys can you see that now?
So,
Okay. Thank you. All right, so this is where I like to put the towel roll under. And this does a couple things. If their knee was already sore, to try to put them in full extension oftentimes hurts, especially if they have a fusion or maybe a cartilage problem. So I like to have a little bend in the knee, A, for my exam, but just to make them feel a little bit more relaxed. You can also, you know, if you're in the field or someplace where you don't have that, you can use your own. I'll do this sometimes, you know, if I'm on the sideline, you can put your own knee or something under there. But for me, this is a nice way just to stabilize the knee rather than just having it lay there. And it also, I say to the patient, okay, just put your leg on there, just relax. They've got a little, you should probably take your shot, sir. They've got a little bit of a bend there, and that just makes them more comfortable when you're doing the exam, because when you do a knee exam, the last thing you want to do is hurt them, because then you're not going to get any kind of an exam at all. When they have a lot of guarding and they're in a lot of pain, and then you yank on their knee, everything spasms down, and now you're like, well, I'm just going for the MRI because I can't do an exam at all at this point. So I will get them here again. Let's switch right here. And again, I'll just feel around, suprapatellar pouch, anything in here, anything in here. I'm checking out here over the fibular head. I always like to check the bony areas. Again, I'll palpate along, check the tibia, up in here, maybe in the medial area. And then I'm ready to check my ligamentous structures. And I will tell you that probably 90% of the time, my biggest worry in a swollen knee is, did they hurt their ACL, right? That's a real typical, I was skiing, or what we get a lot is I was playing ultimate frisbee, I planted, I twisted, I heard a pop, my knee swelled within an hour, and here I am, I can't walk. Feels a little bit unstable. So I'm thinking ACL at that point. Some of our surgeons, depending on how closely you work with them, if you have a good exam that says, hey, their ACL is torn, they'll take them right to surgery for an ACL repair. A lot of times an MRI is indicated, especially for the insurances. They want to know, was there an ACL tear before they'll approve any kind of a surgery. So most of these people end up getting an MRI anyway if we think it's an ACL. But I can have the conversation with the patient right there. Hey, this knee is a lot looser than this one, and particularly on the exam, if I can show them, they feel it. They're like, oh, that really moves a lot versus this, you know. And I kind of at that point lay that, well, we're still going to get the MRI, but I think you probably tore your ACL. There'll be some decisions coming up. Here's kind of what to expect. So if I can get a good exam, I can actually talk to them right there, rather than on the phone 5 days later, oh, by the way, you tore your ACL, which is a little more, you know, it's not a life-threatening thing, but it's a big deal for patients. It's a 9-month recovery, and they have a big surgery. So the ACL, for me, the Lachman test, when I have them in this position, that's probably the most important test that I want to get. I do it first so that if I'm going to hurt them later on with one of the tests, at least I get a good exam here. And basically, that I like to grab down here. I'll usually have my thumb maybe right about on the anterior tibia, right there on the knob. And I like to put my other hand up here, or I'll grab it like this. What you don't want to do is grab somebody, again, over a spot that really hurts. So if, gee, they have a problem right here, and I put my hand on it, and they go, ow, then I can't really get my exam again. So this is just a hard, kind of hardly to show. So anyway, the first thing I'm doing is, here they are, they're nice and relaxed. And I kind of try to do this so you guys can see. And I'm going to check that ACL. And basically, I'm just going, I don't know if you can see that, but she has a nice end point. And it's not a super, it shows a little bit slower on the camera. It's not a great big yank, push kind of an exam. It's subtle. And if you just check a lot of people's knees, pretty soon you'll be able to feel it. She can feel that, you know, can you feel it stop? Yeah, she feels that it stops. The next thing I like to do is just go check their other knee, because I want to see, is she symmetric or not? And so I'll do the same thing over here. And that's all that test is, but it's practice. When the fellows first come, grab knees and they start yanking on him really hard. Well, she's got a swollen knee, and I'm trying to feel kind of a subtle ligament endpoint or not. You know, so it's a lot of it is practice. But I do like to, if you stabilize it, this becomes a lot more like the KT1000 test that the physical therapist will do. So the KT1000 is a little device that actually measures the anterior translation. So if I am not sure of my exam, or I have a patient that's guarding a lot, or gee, they can't afford an MRI, I really want to know, do I have to push them to get it because I think it's an ACL, or gee, it's not. Sometimes I'll send them off to the physical therapist and ask for KT1000. And they put this little device on the knee that holds the knee. It's almost just like this. And then the device pushes down here and it measures translation. And so I'll get a report back that says, left knee is 13 millimeters, right knee is 5. That's bad, right? Versus, gee, they're between 5 and 7 on both sides. Then I can be pretty confident that you didn't tear your ACL. Okay, you don't have to go into debt to get the MRI. We're going to treat you differently, and then if you don't get better, we'll get an MRI later. Because again, I have a lot of college students who still don't have insurance, and for sure never have money, even if they have insurance. So sometimes even the deductible is too much for them. So that's another test that you can use to check an ACL if you have a physical therapist around town who would do a KT1000 for you. And they need to know how to do it. But it's, like I said, it's just a little device that they put their knee in, and they strap it down, and then they measure how far does it move. But really, you should, that should be a test that you can do too. And like I said, she's nice and relaxed, and I think you can see that she has an endpoint there. So that's the test I like to do first when they're relaxed. Sometimes their hamstrings are spasmed, they're really guarding because their knee hurts. And I'll say, try to make your knee just relax on this, just as nice and loose as you can. Really nice and loose, really nice and loose. And I'm not really yanking on her very hard. Does that hurt when I do that? No, but she can feel where it ends. And if it doesn't, you do that and you go, that feels kind of funny. It doesn't feel like there's an endpoint. Go do the other knee. I'll just put something else under him if this knee is really sore, so that I don't take this towel away. I'll either grab another one, or I can grab her here and check her. But go compare to the other side, and you'll start feeling them, and you'll go, wow, there seems like there's a difference there. You'll start getting MRIs, which are nice feedback, because you don't know exactly. You get the feedback, and then they'll say it was a sprain, and you'll go, yeah, I thought I felt an endpoint, and it just moved a little more, versus I don't think I felt anything at all. And so when you do end up getting an MRI afterward, that gives you some feedback on, gee, what happened with my patient. Then the next test I like to do is to check the medial and the lateral collateral ligaments. So again, I'll grab her down here, hopefully where she's not sore, and then I like to put my hand right about at the joint line. And first thing I'll do is just relax a little bench knee. I like them at about 30 degrees. I'll stabilize this side, and I just open like this. Again, I don't know if you can, yeah, you can see that on the camera. So she opens, it's a little bit elastic. It wants to go back as soon as I relax, and she has a nice endpoint on her LCL. And so, like I said, there's a little bit, it's almost like she's got a rubber band there. And so, again, this is a subtle movement. I'm not moving her very far. She can feel it. That's a normal excursion for a lateral collateral. If you don't know, then like I said, you can go to the other side and check that too. I save the MCL for last because medial collateral ligaments are probably the most painful ligaments in the knee. Someone comes in and it really hurts. They're extra articular, and there are a lot of pain fibers there. So the ACLs will come in with a swollen knee, and it hurts, they can't bend it, but it's not a horrible amount of pain. The MCLs come in and they're like, this really, really hurts, acutely and even as it's healing. So I save the MCL for last because I know I'm probably going to hurt them when I do this test, if that's what I'm thinking that they have. So same thing, I get them in about 30 degrees, and I put my hand right over the joint line. Just relax, let you go nice and loose. And then again, you're going to have a harder time seeing this, but it's again that little rubber band feeling where I feel a good endpoint on her. Now you also can check the ligament in full extension. Sometimes if they have an ACL tear, it'll give a little bit there. But that's where I do the MCL, and those you'll feel them gap, and they'll say, oh, that really hurts. and then that's typically what they have is the MCL. Then I like to check for the meniscus stuff. This involves more bending, so again, depending on how swollen or how sore and painful my patient is, I kind of go through the exam with the least aggressive to the more aggressive. And so the first thing I'll do is just say to my patient, can you bend your knee all the way up? And I'll just watch him bend up and down. You bend up and down. Great. Can you straighten it all the way? Good. And then so I know, okay, I'm going to go through with the rest of my exam. So then to check the McMurray's test for the medial meniscus, I actually like to grab right down foot by the heel. And then I like to put my fingers up here so that I'm around on the joint line and that I can feel it. And I'll bend her up. And then what I'm doing now, I'm actually twisting like this and trying to put some pressure on those joint lines. And she'll say, hey, it either hurts on the inside there or it hurts on the outside. The medial side test is the McMurray's, and the outside test is the lateral McMurray's or the reverse McMurray's. But either way, what you're trying to do is bend them up, and then you want to kind of squish, and try to push on those menisci, and they'll say, hey, that really hurts or that doesn't hurt. None of these tests are 100% specific, but if you have somebody who really has joint line tenderness, you know, right there in the lateral, and then I do this and she, gee, that really hurts, that's pretty suspicious for a meniscus tear. And then the last test I do, if they can, is basically the bounce test, where I'll take her and just try to hold her here and relax, and I'll just kind of fully extend her and kind of try to put her in. I'll go bend your knee a little bit and let it go, and I'll do that to her. And that also will really hurt if you have a meniscus tear. Now, if they can, they pass all this and you're really still not sure, hey, could she have a trouble with her meniscus? You can have them do a duck walk where they get down like this and walk, depending on your patient. And that will also stress those menisci and give you a little bit added information. And that's basically what I do on a knee exam. I always want to make sure that, gee, is your ankle okay? Is your hip okay? I'm not dealing with anything else. But those are the basic tests that should give you enough information. Do I need an x-ray? Do I need an MRI? Do I need a referral? And like I said, when they come in with a big, fat, swollen knee, that effusion, it's going to be harder to do your exam. They hurt. And again, you just don't have as much movement because that joint is filled with fluid. Sometimes patients come in and their knee's big, fat, swollen knee, and they've fallen directly on their knee. And you're trying to tell, gee, do I have an interarticular problem, you know, i.e. a fracture, or do I have something extra-articular like the prepatellar bursa? And it can, you know, sometimes you can just look at that knee and you go, wow, that's really full of fluid, I can't quite tell. And the way to tell the difference, and this is, again, none of these tests are 100%, but if you want to see, hey, is this a prepatellar bursa swelling versus an intra-articular swelling, is you can kind of milk the fluid, and you can push it down and push it up. And if it's intra-articular, they should still just have that little layer of skin and connective tissue over the patella. There shouldn't be a big water balloon on top of her patella. So I can kind of milk it and feel it, but I can still feel her patella really well with my thumb. If I milk it and do this, and everything is here, all of a sudden I have this big fat water balloon on top of her patella, that's better for the patient, right? Prepatellar bursitis. You know, they used to call it housemaid's knee. The guys who lay tile, anyone who's on their knee a lot will get it. But that's something that's going to heal up with conservative treatment. So and even if you have a little, you can kind of try to push it around, and then you can see, can I still feel that patella? Yeah, this must be intra-articular versus boink, I've got a big water balloon on top of the knee. Then I know that that's the difference between the intra-articular and the extra-articular. So what questions do you guys have? When patients come in, what do you want to know? What are the hard tests? What's confusing?
Doc, when you say conservative treatment, can you hear me?
Yep.
When you say conservative treatment, what does that entail? Like,
Prepatellar bursitis?
yeah.
Yeah. So first off, when they first come in, what's happened with the prepatellar bursitis, typically you might get, Christy, you might get somebody who does have kind of a chronic bursitis if they're on their knees a lot. And, you know, hopefully they're wearing knee pads. It's hard to be on your knees a lot, but sometimes, you know, those people still get it. But let's just say an acute. And at the health center last month, we had 3 or 4 that came in. They slipped on the ice. We had a bunch of snow up there. They fell, and they hit directly on their knee. They come in with a swollen knee. For sure, those always get an x-ray for me. If they have some kind of a trauma, you need to get a plain film x-ray to look. And then, hey, the x-ray's normal. I come back and look at them. Maybe there's a little bit of abrasion here, and I really milk it, and I see this big fat swelling. What that is blood. It's acute bleeding. And let's just say she did it this morning and came to see me this afternoon. I can aspirate that fluid, but there's not a lot of pressure in this area. There's not a joint capsule. So what's going to happen is she's going to just fill right back up with blood again. So I typically don't aspirate them on that first visit. What I'll do with them is make sure, hey, the x-ray's okay. You don't have a fracture. This is the glide sac, around your patella in your kneecap that got bruised and it bled inside. It's going to get better. Here's what we're going to do. I really have them ice it. If they're really sore, you can put them on crutches for a couple days, but most of the time you don't need that. And we'll show them how to wrap it pretty tight with an ACE and some Coban. The little knee sleeves that have the hole in them aren't any good because the fluid just pokes out through the hole. And it's uncomfortable to put pressure on the patella, so it's a lot better to wrap them up. And then I will typically say, Advil or Aleve or a Voltaren or something, depending on, again, do you have it at home? Can we give you some samples where you get it? And then I'll see them back in, a week or 2 usually. I always warn them about infection because sometimes those things do get infected and then you get a septic bursitis on top of your traumatic bursitis. So then I'll come in, let's just say she comes back in 2 weeks. Well, let's just a week and a half, 2 weeks. Most of the time, it's better. It's starting to organize. It's thickened up there. The patient says, gee, it's pretty thick. Should we aspirate it? If you try to aspirate one that's really thick, it's all loculated. It's resolving. You can't really get anything out of it. But then once in a while, a patient comes back in, and it's a water balloon. And it's just full of fluid, and I can actually hit it and bounce it around. And I'm like, oh, that's something I could actually get the fluid out of. So I just get I'll numb them up and just get a big 18 gauge and some big syringes, depending on how much I think I'm going to get out of there, and take it out. The problem with poking through there, especially if you get through the bursa, is sometimes it leaks. So you can do the little Z-tracking thing, where if I'm going to, instead of going straight in, what you do is you'll just pull the skin up a little bit or have your assistant go in, draw your fluid out, and then when you take it out, the skin relaxes and kind of covers the inside hole. So then the inside and the outside, does that make sense? The inside and the outside hole aren't in the same place. Rather than just making a hole straight through everything, I'll pull this up, go through there, aspirate, and then it kind of relaxes. And so that's what I'll do with those. Sometimes they get infected. And again, I had 3 of them last month. 2 weren't infected and 1 guy was. And he had a big, ugly, worrisome knee. You always worry about MRSA, even though it's a traumatic thing. MRSA is probably what's going to do the worst. And I will, in our clinic, what we really have to give is Rocephin and typically Bactrim or Doxy, depending on what they're allergic to. And then follow those really closely. If you think it's intra-articular infection, of course, they need to go to ortho right away. Again, depends on the history, and if you're not sure, you can send them. All those traumas should have an x-ray too. Every once in a while you'll be fooled and you'll see something. Trauma to that kneecap, you need to make sure they can extend their leg. So can you lift your leg off the table? Great. Her extensor mechanism is intact. She doesn't have a fracture through her patella. She hasn't torn her patellar tendon. She hasn't torn off up in the superior area. So patient has that kind of a trauma, can you lift your leg? Yeah, typically they don't have one of those bad type of injuries. When you see something like that, you can usually palpate the big divot where the patellar tendon was, and then their patella will be up here. Sometimes they're really swollen and you can't tell. You'll see it on the knee X-ray. The patella is way up here. It's more than patella alta. And then you go, okay, we're going to put you in a, that's about the only time a straight leg immobilizer and over to the orthopedic surgeon. But the conservative treatment for the bursitis is basically that. So I don't typically aspirate right away. If someone's totally uncomfortable, I might, but you have to wrap them tight and know that a lot of that may reaccumulate. What else? So pretty straightforward as far as what you're looking for. And, you know, I think that Lachman test, to get good at that is to just practice on people's knees. And they won't notice if they're there for a physical exam if you say, hey, I just want to feel your knee, you know. And pretty soon you'll just get good at that kind of rocking motion. People like to do it differently. You can do the anterior drawer test as well, where you bend them up. We didn't talk a lot about the PCL, but the anterior drawer test, I like to actually sit on their foot or put something on their foot so that I can, and again, I put my thumbs in the divot, and I grab back here. Does that hurt? Is that really sore? My patient says, no, it's okay. And I will pull forward and push back and pull forward and push back. And again, I can feel that she stops there and stops there. It's not as sensitive of a test, and if they're really tender, it's not as comfortable of a test. And then, let me switch you forward and we'll just let you lay down here. And the other test you can do for the PCL, which occurs sometimes too, is a test where you call it the SAG sign. So you just get the patient like this, and basically, if the PCL is torn, there's a picture in your, I put a picture in the handout, but if the PCL is torn, you get this little C sign or this SAG sign, and you can actually say, hey, let's look at both of them, and you look from the side, and this one falls back because the PCL is not there anymore, and it falls back. Sometimes you can also see that, I'll say to the patient, can you contract your quad for me? So go ahead, contract, yeah, perfect. And sometimes you'll see it go boink, 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 up and down. So that's another, those are some other tests that you can use. It's a little bit harder without experience to do the PCL, but you can just grab them here sometimes and push back and go, wow, it really does go back. And isolated PCL is a good injury. It's typically non-operative injury. Again, depending on if you're trying to return them to sport or what you might be doing with them, they may get an MRI out of it. But again, that's something that you treat conservatively. And there's some special tape jobs for it. If you have therapists that'll tape them, you can use a brace. If we're going to try to have someone play after 2 weeks, we'll do the tape job and the brace over the top. And the people who know how to do this tape job are the rodeo athletic trainers, because this is such a common injury when you fall off your horse and you land with your knees on the ground. Boom. You know, your tibia goes posterior and you tear your PCL. So most of the guys who are the ropers don't have PCLs. And you know, it's about 2 weeks of being sore, and then they get back into it and they do fine with it. Some of the football linemen, a lot of the linemen in the NFL don't have PCLs either. They just tear them when they're down on the knees. And like I said, they do really well. It scars back in, and it doesn't cause a lot of disability if it's isolated. But it's another thing to think about. You just won't see it as commonly unless that's the mechanism. I went straight down on my knees. You can't always tell if there's a, you know, when you have an ACL injury, the terrible triad is, and they tear their medial meniscus and they tear their medial collateral ligament. So those really, when they're sore there, and you have what feels like an unstable knee, those really do need an MRI to see, hey, what's going on in there. With our surgeons, sometimes, like I said, if I can really, I have a KT1000 that says she's 15 on this side and 5 on this side, and she's going to self-pay for her ACL surgery. A lot of times they'll skip the MRI. They know if they go, they'll talk to her ahead of time. I know if I go in, we may need to repair your meniscus, or we may need to take some of it out, and then they'll just, you know, see what's in there. Again, that's pretty rare, but sometimes if you have a patient who doesn't, you know, has limited resources, some of your surgeons will do that based on an exam. What other questions? Baker cyst? Yeah?
Oh, can you kind of run down the injuries, and these are the ones that are for referral, and these are the ones that are conservative?
Yeah, so I won't refer to prepatellar bursitis, and I will tell you in my clinic, 90% of the people who walk in with my knee's been hurting off and on for the last year are probably patellofemoral syndrome and not meniscus tear. It can be a little bit tricky. So patellofemoral syndrome, what we're talking about is the patella itself doesn't necessarily track in the groove as well as it should. And we used to think that was just because the inside of the knee was weak, the outside is strong. Gee, she's a runner, she does a lot of running, and you get tight out here, and it would kind of pull the patella off. And then we said, in women, have a little wider hip than men, we think the patella is going this way. Well, interestingly enough, now we think it probably relates back to the small muscles in the hip and strength there, multifactorial. But probably more of a biomechanical imbalance in other parts of your body, and the poor knee gets the brunt of it. So a lot of times these will be runners. It hurts off and on, and I ran Mount Rose, and uphill was fine, and downhill was really hurting. I'll do an exam, ligaments are stable, tender peripatellar, then I'll talk to them about treatment, and if I can get them to the physical therapist for that, it's really helpful because they will, they'll teach them about stretching the IT band, stretching the hamstring, still trying to strengthen the inside, getting them on a bike. But there are the hip exercises that we put out there, I think under shin splints or something. We have the hip exercises on the hand. Those really help too. And those are just those two little exercises with the TheraBand where they go back like this, basically, and then, they're going out like that. Just those two exercises tend to help that. So again, if my patients can't afford physical therapy, I give them a handout, I get them really stretching, we cross-train, stop that kind of running for right now, let's put you on the bike, let's get you swimming, let's get you doing something else. So that's a treat conservatively all the time, because they go to the orthopedic surgeon and the surgeon's like, there's nothing wrong with your knee. They come back to me, or they get an MRI that shows a little bit of irritation under the patella, and they probably really didn't need that. So I don't necessarily even get an X-ray on them the first time, depending on how long it's been going on. But I do think that it is important to get X-rays on knee things, on stuff that's been going on longer. Every once in a while we find something really strange. And not too long ago, there was a gal who had some pain laterally, and kind of seemed like it was just going to be an overuse syndrome, and she had a big, tumor in her fibular head that turned out to be not malignant. She still underwent a big surgery. So I think it's a good idea when they've had it for longer than a couple weeks to go ahead and get the plain film and make sure you're not dealing with something else. As far as the MRI, you have a little bit of time for that, because even the meniscus tears a lot of times heal with conservative therapy. So if someone comes in and it's only been 3 days and I think they probably do have a meniscus tear, I'm still willing to put them through a few weeks of therapy before I order the MRI, because there are some that'll heal up and you don't have to do that. But that locking thing, gee, my knee gets caught and it locks, sometimes that's from the patellofemoral stuff under the kneecap, and they get that feeling, or they'll have that crepitus, and that's not necessarily a meniscus tear either. Isolated MCL, I typically don't send. I'll treat that with a brace. And again, it depends on your level of comfort and what the patient has to get back to and what they have to do. If I think there's anything, if I have a bad MCL that really gaps open, I probably do get an MRI, and then I want to see what that medial meniscus looks like. And again, depending on how well I can do the exam, if I can't tell the ACL or not, I'm more suspicious in that. The lateral collaterals typically heal up conservatively. PCLs typically conservatively. So the stuff that needs to be managed surgically are the ACLs and the menisci. And once in a while, if there's an MCL, based on where it is and how bad it is. But most of the time, even on a 3rd degree, those don't get fixed unless you're a higher level athlete. So I'd probably take care of 80% of the knee stuff. The contusions, the bruises, the iliotibial band, I'll come in with pain right in here. That muscle narrows down to a really tight fascia there. Again, there's a bursa underneath it, comes across and attaches right in here. The runners, especially the runners who go in the same direction all the time, like they run around a bank track or on a route that one leg is higher than the other all the time, they'll come in with some of that iliotibial band. They'll be really tight. Sometimes just changing them to run in the opposite direction helps. But again, stretching on them, rolling it out, you can inject those. A pezanserine bursitis is on this side of the knee down here. There's another little bursa right there. And again, they're just going to be tender over that. That's your 3 muscles that come into the pezanserine bursa. You can inject them. You can treat those conservatively. So I would tell you, Krista, a lot of stuff is treated conservatively. Patellar tendonitis. Now I really push over that patella and it hurts. And maybe sometimes they also have that catching locking. And when, again, especially when the fellows are new, they get a lot of MRIs for that. And then it comes back and they go, gee, it's just patellar tendonitis, but that tendon is swollen and it's catching. And the patient feels that as a locking and a clicking. Again, you know, trying to modify treating conservatively, but I find pretty good luck when I can't get them better with that with using nitroglycerin patches. You know, so I tell the patient, this is a medicine that we give people for heart disease, but you're going to put it on your knee, and I'll have them cut a 0.1 milligram patch in half, and they put it on for 12 hours. So I'd say to her, put it on before you go to bed, take it off in the morning. And if you leave it on for 24 hours, you develop some tolerance to it. And interestingly, and it's supposed to be for 12 weeks, but I will tell you, interestingly enough, sometimes in desperation during basketball or volleyball season, because the people who get the bad patellar tendonitis are the people who jump really high. So sometimes in desperation, it's our starting, you know, forward. I put it on. I don't know if it's the placebo effect or what, but in 2 days they'll go, oh, my knee feels better. It's not supposed to work that way, but it does. It doesn't drop their blood pressure enough to typically cause problems. They might get a headache the first night or two. I tell them just use Tylenol. But again, you can get the small patches and cut them in half. So I can tell you that a lot of stuff in the knee you could treat in your office and treat conservatively. What other questions?
This is Diane. I have a question. How do you decide between like a hinged knee joint, a knee immobilizer, the one with the hole in it, the neoprene you were talking about?
Okay. So a knee immobilizer, you remember that one, right? Everybody comes in like this. Really only should be used for the patellar mechanism. So that's a patellar rupture or patella fracture. Because what happens is you may see them in the clinic or the ER and say, follow up with your doctor in 3 days. They come in 3 weeks later because they couldn't get in or they were busy. And they've been wearing this thing the whole time. And now their whole leg is atrophied. So all musculature is gone. And it's like, well, now we have another problem on top of it. So I'm not a big fan of the knee immobilizer except for certain, you know, I think it's a fracture. Like I said, usually a patellar mechanism rupture. So I have a tear here, I have a patella fracture, I have a tear somewhere here. That's fine, and those really do need to be seen soon, so I make sure they get into somebody fairly quickly. The hinged knee brace is what I like to use for the MCL and the LCL. And those are, you know, it's a hinge. Most of them have a hole for the patella because it's more comfortable for the patient to have a hole there and a hole back in the back, especially if they have some swelling. And then the knee sleeve, I will use sort of as a proprioceptive device or a, you know, you just have a bruise, I think it's going to get better. It keeps your knee warm. What it really does is it keeps the patient's brain focused on protecting that knee a little bit. So I'll use those for some of the, I might use it for a patellofemoral kind of a thing. Patellofemoral syndrome, they have some interesting braces that have a buttress that are supposed to be able to kind of pull the patella over to the side. The physical therapist will sometimes use a McConnell taping. They may use a rock tape or a kinesio tape. Those things don't really I can't overcome her patella with a piece of tape. But what they do is they keep her focused on a little bit different mechanics, and maybe keeping this muscle activated. And so there's a proprioceptive mechanism to those things. So a lot of the times the physical therapist will tape them, or I will tape them and say, how does that feel? And they say, hey, it feels better. We'll go ahead and use it. So there's also a place for that. But the knee sleeve I just use more for things that I think are minor, that are going to get better on their own. I might, if I inject an iliotibial band, I might say, here, wear this for 2 weeks. It's more proprioceptive than anything else. And sometimes people like to have something on their knee so everyone knows they got hurt. If they have to go back to practice or something, my coach is going to think there's nothing wrong. I'm like, oh, perfect. Here's a knee sleeve. Wear that for 2 weeks and come back and see me. And, then all of a sudden it's like, oh, she must have an injury. So there's some other secondary gain to that kind of stuff. But that's basically what I use those for. If I think I have an ACL, I don't necessarily, I might put them on crutches depending on how comfortable they are and wrap them. I don't necessarily put them in a brace. And you'll see more and more that after ACL surgery, that physicians, the orthopedic surgeons don't have them in a brace. They may have crutches for a couple days and then walking is tolerated. So I had a young lady come in yesterday who tore her ACL on the ski hill, and she had to go. She went home over break to California and had her ACL fixed, and she came back in a brace from here to here that's locked out. And she's been in it for 3 weeks, and I said, when is he going to get you out of that? And she said, the middle of May. And I'm like, it's the surgeons. But the studies show that you definitely don't need to do that. So I think we were a little bit, we were probably a little bit more hopeful that the braces would help than they are. There's no brace that prevents ACL injuries. You'll see those, all the linemen in the football teams wear those braces to try to prevent MCL injuries because they get hit a lot, and they want to try to prevent that. And there was one really old study that said, gee, maybe it helped. And then there's a few more since then that said, because it changes your proprioception, and I've got this big brace around the upper part of her leg, she doesn't get as good blood supply, and now she's more susceptible to an ACL injury. Well, I would definitely much rather have my student athlete get an MCL injury than an ACL injury. So you don't see them wearing those braces in the pros, and a lot of the football, and some of the football teams who actually look at the research take their kids out of it. But the kids and the coaches and the athletic trainers believe with all their heart that they got to be in a brace to prevent injuries. And when you look at the amount of movement needed to tear your ACL, it's just a couple millimeters if it's taught in the wrong direction, and those braces don't do anywhere near that. So braces are sort of, I do like the hinged one for the MCL. They do feel like that gives them a little bit of support. And the knee immobilizer, I could totally do without that if I had to. And the knee sleeve is more for, it's just going to make your knee better, but not a lot of therapeutic. So, you'll find 100 different ideas on that though, Diane. So that's just the way I do it.
Okay, thank you. So now I have another question. What about noises in the knees? Like I have an older patient that when he gets into that duck walk position, it sounds like Rice Krispie treats in there and snap, crackle, pop, and you can hear it externally.
So probably some patellofemoral compartment. So when I talk about that compartment, that's not the knee joint proper where the menisci and the ACL and the PCL are. It's another compartment that is the patella gliding up and down, basically on the femur in that track. And they'll get some kind of thickening, and you used to call it chondromalacia patella, thickening underneath that kneecap. And that's probably just wear and tear. It may mean some arthritis or degenerative changes, but as long as it doesn't hurt, I leave them alone. I just make sure, gee, is this person, are their knees going to be in good shape anyway? Is he at a good weight? Does he exercise? There are some studies that say doing some weightlifting exercises for folks in that age group can help it. If it's just noisy but it doesn't hurt them, I usually leave them alone. If it's noisy and it hurts, it's probably going to be that patellofemoral compartment, and you'll see the kind of osteophytes and problems on the lateral view of the knee, and that's kind of a problem because they end up with a total knee too if they're having a lot of pain. really only, they didn't need, it was more their patella. So there's some people who are doing some studies on just patella replacements and some new types of surgeries, but those are tough ones to see. A lot of times what we'll see is like a 30-year-old baseball catcher or softball catcher who did spend a lot of time squatting, and we'll have that patellofemoral compartment. And interestingly enough, sometimes they'll get an effusion, they'll swell. It'll be just right out here. They'll just come in here with this. And if you try to put a needle in the knee joint proper, you don't get any fluid. So you go right in that compartment and get it. But if they have a lot of noise but no pain, I just leave them alone.
Can't hear that.
It's only when it's bending. Only getting into that squatting position, getting out of it. Regular walking and stuff is not painful.
Yeah, so if he can, so we, again, had a player on our football team who was our center, who every single, and he had bad patellofemoral. So as soon as he was done, we said, no more squatting, or less, don't get into a job where you do that. But it's probably that patellofemoral compartment arthritis, and you'd manage that conservatively. But doing some strengthening and some stretching for that knee can help take some of that pressure off, but you really don't want them down in that position if at all possible. And if, gee, that's what I do for work, then it's got to be modified in some other way. So, it's kind of one of those, well, don't do that then. But it's probably his patellofemoral joint that's causing him the problem. And if you look carefully on the lateral, you may see some osteophytes around the patella and in that area. Or you can ask the radiologist to review it.
Thank you. So now I have another one. The hip knee that you were talking about.
Yep.
There's a patient that started with the knee pain and has been favoring the knee and now has the hip pain.
Yeah.
Do I need to do any imaging of the knee pain or the hip, or should that just go straight to physical therapy, or?
Well, I get a little more worried about hips, especially if there's any chance of, could I have some kind of a fracture or something? Because completing a hip fracture is really life-changing for the patient. So it depends on the age. Do I have an eating disorder? An overuse thing, depending. So, or am I just dealing with osteoarthritis there? So I probably tend to image the hips in that case. But knee pain, exactly what will happen is it starts down there and goes upstream. So people who don't have very good dorsal, aren't very tight, will oftentimes have. So everything kind of starts and heads up. With the knee and the hip connection, what we think happens is if my little hip muscles are weak, the muscles that keep my hips from going like this when I'm running, and so I'm doing a lot of this on top, and now I find myself watching people as they run, going, oh, we could fix her with a little of this or a little of that. So when you see them run, and they have a lot of this kind of motion, look what that does to my knee, my hip, my ankle, everything else. If I'm pretty stable when I'm running and my hips aren't tweaking back and forth like that, I tend to not put these things in weird positions. So if you're going to do, it's core, it's hip, and that usually fixes what's downstream. But, now my hip hurts a lot. I tend to x-ray those.
Okay, he's had some knee injections that have helped with the knee pain. And now the knee feels so-so, but now the hip's starting to hurt. He's 43.
Yeah, I'd x-ray him and make sure he didn't along the way. Some of these in their 40 and 50-year-olds had hip impingement along the way or labral tear, and now I'm seeing them with some pretty bad arthritis at a young age. So I get that look, but then when physical therapy, I really work on core and hip with that person if I don't have a horrible-looking x-ray. Now, even if I do have a horrible-looking x-ray, I may still give them a trial of, again, they may need an injection there, they get therapy, they get conservative care. If I don't have to replace a hip on a 43-year-old, I don't want to. But, again, look at your x-ray and see where you are with that. That looks okay, then I do go to therapy. Then when they fail therapy, I start doing some other things.
Okay, thank you.
All right. Next month, we're going to have one of our orthopedic surgeons from Las Vegas talk about the elbow and the ulnar collateral ligament injuries. And you might think, gee, that's only in professional pitchers, right? But a lot of these young kids with overuse are having these ulnar collateral ligament surgeries at really young ages, which, you know, I'm not necessarily sure is a good thing. So it's Dr. McGee from Vegas, and he's done sports fellowship, and he's going to talk to us about elbow injuries and then surgery for if indicated. So it's not something that you probably see a lot of, but when you do, you really want to know who to send them to, because a lot of general orthopedists don't do those kind of surgeries, and you know, it's a little specialized deal. So you might want to come listen to that one next month. Okay? Have a good day.
Thank you.
Good.